See, I saw you last night. See you today. So it's 1 minute after, like I said, and we're going to get going. So, as I said, it's week 6. It is now going into exam 2. There is a lot of information. And Navila did have already her uh, class this week. So, and Yukari. So at least they had week 6 in there now to start to understand. Remember, everything is posted everywhere. You can go look at anybody's review. I always encourage one live at least, and then listening to somebody else. I don't care who it is, whoever you bond with. All right. There's some people don't like this one, don't like that one. But pick which one you want. Between all of us, I think we have a great group of professors that describe it all a little differently. So let's go into the cognitive and sensory, which lets the sensory's eyes. Let's look at the eyes. So there are 3 different type of eye conditions that we talk about. We talk about amblyopia, so lazy eye. It's like the picture. One eye is just not straight. So how do we get that eye working again? Well, the good eye is working well. The muscles are good. It's straight ahead. But that lazy eye, there's a muscle that's weak. So we put a patch on the good eye and say, bad eye, you need to work now. Do your exercises, strengthen it, and then usually that's all it needs to get it straightened out. Now, strabismus, it looks like cross-eyed, okay? But what it is each eye doesn't know how to work together and they cross. So they're seeing different areas and it makes you dizzy, et cetera, all that stuff. But this is strabismus. They do not align and they go past midpoint is the definition of it. And again, exercises usually helps us out and maybe glasses. The other one is nystagmus is where they just jiggle, okay? There's jerky movements. Could be up and down, sideways, all different ways. All right, cognitive impairment. Well, we know cognitive impairment, it could be a child who looks differently. That could be your Down syndrome, right? It doesn't always mean cognitively impaired children look differently, though, okay? What sometimes you see is the symptoms of it. And what we see is they're irritable, and you don't know why, because they don't understand, is what the reason is. They don't respond to their environments, they don't respond to name calling. You're going to see those delays that first year of fine motor, gross motor. They're just not going to be doing the grasp. They're not going to be up on their knees crawling and walking by the age 12 months. You know, maybe their head is lagging and it doesn't get that neck strength by 3 months. They're not rolling over by 6 months. These are things that you see. And using those little fingers with that pincer grasp, it still might be a crude one at the end of the year, which is a delay. Of course, language you're going to see, they may not be able to say mama or dada. And again, what's this going to do to a child that can't communicate? They're going to have behavior difficulties. Why? They can't communicate and they're not going to be meeting their milestones. So Down syndrome is one of those cognitively impaired children. And again, they are mild to quite severe. Mild Down's children are trainable and can go off and live on their own and get jobs. Go to college, some of them can, with some extra help. So Down syndrome, what do you usually see? So short, stubby fingers, toes. You have that palate is large, really tall in their mouth, this big tongue, and these almond eyes. Many of them have cardiac defects, simple as a ventricular septal defect, a hole between their ventricles, or even some of the more severe, like truncus or AV canal. Also, they have this little, their nose is flat. And because of that nasal bone, mucus gets caught there. And they get a lot of respiratory infections from that, which is the underdeveloped nasal bone there on the bottom. They're very hypotonic, which means they can put their legs behind both feet behind their neck. And they're just so flexible, right? Part of what you see. Also, you have that semian crease. You can see sometimes you can't tell at birth. We start looking at their palms and seeing it. And then there's this big wide space between their big toe, the second toe, it sort of spreads out there. Now, children who are with cognitive delays have a lot of concerns. They get really stressed, a very high anxiety. They do not want to be away from mommy and daddy. So, how do we treat these children and that anxiety in the hospital? Let mommy and daddy stay with them as much as possible, right? They're the one who can comfort them. Usually it's just mommy and daddy. It might be Nana or Pop Pop, right? But whoever, let somebody stay with them. Now, talking about verbal, most children are making sounds from the moment they're born. They're crying, and that is their voice, okay? Then all of a sudden they start cooing. My little 3-month-old new grandson all of a sudden has found his voice and is screaming as he's hitting a toy on his high chair, and you can hear him. And she sent me this thing. He goes, "Oh, you found your voice." And that's the cooing, the gurgling, the laughing, all of that stuff. Perfectly normal. By 8 months, they're trying to say what you say. That's when you're starting to say mama, right? And I'm like, no, nana, nana, and mommy and daddy and grandma and grandpa are all trying to make them say their name. And they do, they imitate it. By 10 months, they're starting to understand when you say no. We know that mama, dad, that starts because they're imitating. And then by 1 year, they might know milk. They might say more. They might say mama, dad, that. And hopefully they say nana in my household. So they do understand, how to verbalize normally, not there's no cognitive delays in them. Now, if you have an infant who's not responding to you, or you have to speak louder, or you have to be seen for a reaction, well, or they're not talking, number one, check them for hearing loss. Remember, speech and hearing go hand in hand. They're not speaking well. Number one important thing, check their hearing. It could be that they're not hearing. Autism is something that children can get. It is a cognitive delay. It is mostly boys. Um, you usually don't diagnose these till about 2 years old. We might see some symptoms earlier, but the true diagnosis is not done till about 2 years old. What would you see in a child who is autistic? Well, these children don't like look at your eyes, and they don't like you looking at theirs. They sort of talk to you, but they're looking all over and they're avoiding that eye contact. They're not really responding to their name. This child's not going to imitate what you're doing at all. They don't understand how to do that. They're also going to do what we call repetitive behaviors. I've told my class, I had this one child, he was a Downs autistic child, so severely cognitively delayed. But he had been in daycare, specialized daycare from the very beginning of life. But you could watch this child, once he got into the classroom, would sit there and do the same thing over and over and over again. Get the toy, put it on a chair, get a something, put on top of the toy, take something else and put it there. Take this one off, take the other one off, take the truck off. And he went back and forth 20 times. And that gives them comfort, okay? They are absolutely going to have speech and motor delays. They're not going to have that fine pincer grasp by the end of a year. Absolutely not. It could be even into the second year. They like to play alone. They don't like other children. Sometimes food, you got to be careful. Textures, they don't like. They don't like loud noise or bright lights. So you have to be very careful. And as I said, it's sometimes you can see the signs, but it's usually not discovered till about 2 to toddler years. Now, immunizations are important. We know that they help prevent these diseases that vaccines can prevent. Well, there are times you have to be very careful with giving them. Now, what if you have a child who has cancer? Do you give them their vaccines? Well, you never give a live vaccine to an immunosuppressed child. That would be a child with cancer. Now, in med-surg 2, any person on steroids is rendered immunosuppressed. They will not get a live vaccine too, okay? And then the parents ask, "Well, what about my, other children and me and my husband? Can they get it?" Well, absolutely. They can get it. It's not going to be a risk for that child. Now, how do we talk to children and adults about getting them immunized? Well, we know that there are children, and I've seen quite a few in my career. I worked in the ER, so I saw lots of children come through that weren't vaccinated, and it was for many different reasons. Some of them say it's religious. I don't delve into it further. It's their own personal choice. Sometimes it's their belief, or they're worried about safety. Um, Remember that chickenpox vaccine that came out and many years ago, a physicians said that it caused autism. So then all of a sudden, nobody wanted to get that varicella vaccine, right? And then they found out that physician was it was a false study. It didn't happen. So, but these things happen, and parents read a lot. We call it Dr. Google, right? They go into Google, they look everything up, and they not going to do it. I mean, I understand being safe for your children. So another thing is us as healthcare providers, what can we tell them about vaccines and the safety of them and what to expect from them? Okay. We know the first vaccine given, Hep B, at hospital, usually before discharge. Now, you have children that might spend a long time in the hospital. And, whether they're adults or they're children, we know that good nutrition helps in healing, right? Protein is what helps heal all of these things. So, good nutrition is always your first thing. The draw sheets, we use them in adults. Well, we can just use a baby blanket under a little infant and pull it up. It's still considered a draw sheet. It doesn't shear or rub against the sheets, which can cause, and little infants, young children, it can damage their skin. So, draw sheets, using skin moisturizer, keeping it nice and soft, keeping them dry, whether they're with diapers or just a pad underneath them, turning them every 2 hours, the cough, the deep breathe, worried about all of the, blood clots, etc. All these things are important. And then we're going to use all the things to reduce pressure. Many older kids can get those air beds, and that can help, with these longer term children. These children can get decubituses. They can get foot drop, just like adults. So we need to be very careful turning and positioning them. I use all the time babies' blankets, babies' toys, um, pillows, all of that to prop them up and over with. And all those things are absolutely appropriate. I would have a kid looking at a toy, then looking at something else, right? Sort of gets them comfort. So, how do we take care of a kid in the hospital and how do we do an assessment? Well, I've always said if a baby's asleep in mother's arms or comfortable, listen to their heart and lungs first. That's always because you're not going to do head to toe like adults. It's not going to happen. When you have head to toe with adults, it's because they're sitting there for you. And you're not going to get that with children. They're scared, they're afraid of you, and you are somebody who gives shots. You are, you're feared. So you've number one got to get them comfortable. On mommy's lap is the absolute best place to do anything. And of course, you get below them, not above them. You get on their level, open up the dialogue, make them feel comfortable, and then you can start letting them touch the stuff and the equipment and pushing buttons for you. And you'll get a lot more done when you have that child helping you, believe it or not. Now, during the hospitalizations, some kids are in there for longer periods of time, and you'll see some kids that are really scared for whatever reason. Well, we need to know what that reason is, right? We need to know what caused that child to have so much fear. And there's different ways we can do it. We can do expressive activities, which can show them if they're angry, upset. We can see that they're upset by this, by the way that they're treating the toys, whatnot. Dramatic play. This is a well organized technique, and it allows that child to tell you what happened when that caused them to be upset. Was it the getting the IV started? Or was it getting put in that CAT scan? They didn't like that circle over their head. What was it? And they can reenact that through dramatic play. And then creative expression. Give an older kid, a crayon and a piece of paper and tell them how they're feeling about their hospital or what did they like about the hospital or what scared them. They're going to be truthful and they're going to draw it. One of the things that we have to worry about is children and then addressing their pain. Kids are not going to tell you they're in pain. Why? They don't want a shot. They don't like medicine, right? And they don't know they can ask. So the first thing we need to do is if we're going to take care of a child and we know that there's a possibility of pain, find out when was the last dose they got, and if it's time, bring it in and medicate them and tell them why. Then you can get them up, get them out of bed, coughing, deep breathing, doing whatever you need to do, but don't try to do it without medicating them first. It's just not going to work. It's not going to be as effective, and that's why you're doing that. And always with the younger kids, distraction techniques. You might need to do coughing and deep breathing with a younger kid, but let's put some music on and let's dance after some pain medicine. And now the hands and arms are going, they're dancing, and what are they doing? They're coughing and deep breathing. You tricked them into it by a distraction. Tylenol is given for the first 6 months of life only. We do not add in the ibuprofen till after 6 months. Something to do with bleeding coagulopathies in the younger children's, and we shouldn't give it. One dose that's given early, okay, you tell the parents not to do it, but a continued all the time could cause problems, okay? It's similar like aspirin. Never, ever give aspirin. It's never a recommendation to give aspirin. If there's nothing in the house, you give nothing. Undress them, giving something cool, right? Aspirin can cause problems like Gray syndrome. The only time we give aspirin is Kawasaki disease, right? Because we need it there to prevent clots to thin the blood. Now, children are small and little IV fluids can cause a lot of problems. If you look at that arm on that child, that whole arm from the elbow down is swollen. That could be 10, 15 mLs of fluid. On me and you, it's nothing. On an infant's a lot. Number one, turn it off. Number one, turn it off. Then, depending what's been infused in there, if it's something that's caustic that needs some sort of other treatment, then you would tell the doctor. Those are usually things like your vasopressors, like dopamine, dobutamine. Those things might need something in there, but normally you stop the infusion, you take out the IV site, you're going to elevate it, put warm on it so that we can get that blood flowing again, and elevating it's going to help, that fluid come out of the arm. I've seen whole tops of hands, absolutely turn black from caustic medicine. So be aware of what's infusing in there. Now, gastrostomy tubes is a way to be fed, and they are great. We know there's all different types of gastrostomy tubes. There's one that's we call a little button, and that's the one on the right that has just the extension tube on it when we need it. And then there's the one that looks like a Foley catheter that sticks out, that you always have that. And one of the questions nurses always ask, why don't all of them have just a little button? They're just so much safer. Has to do with insurance, believe it or not. I hate to say it, but that's the only thing that I've said. Or the younger kids, they say use the tube one. As they get older, they'll put in the button one when they're more active. Well, infants do pull the little ones too, those big long tubes. So clean it, soap and water. That's it. You don't start to spin it and all that sort of stuff. And just keep a clean little gauze underneath. And that's just to protect the skin. Oxygen. Well, the easiest, best, and most accurately given oxygen to an infant is that good old oxyhood. And what they do is they put a sensor underneath in there, and then you dial up the oxygen, and it tells you exactly what's in there. And look at that infant looking around, comfortable, nothing's tickling their nose, there's no tape on their face, and they do very well like that, breathing nice and easy, and it's not a problem. Nasal cannulas, they pull it. They got air flowing in there, it tickles. Have you ever been intubated? I have. It is not fun, and I do remember it. It was after I had some big surgery. I woke up and I felt like I was not breathing, and I knew I was breathing because there's a tube there. So it being intubated and CPAP, it just this air is being pushed up in my nose. So easiest oxyhood. Just as some information for you, you don't have to know all the percentages, but look at the difference of airflow to how much FiO2 or oxygen can be delivered. But would you ever put 10 liters of oxygen blowing in to a young premature infant's nose? You're just going to blow up the belly too, right? So no, we usually a quarter a liter, a half a liter, 22%, 23%. That's all we would do mostly on that with younger children in a cannula. Now, the best way to get a urine specimen on an infant is catheterization. And you're saying, oh my God, but that seems so radical. Well, think about an infant. They have no immune system, right? Their mommy's immune antigens are going away really, really quick. So we don't have the chance to, well, if this medicine don't work, antibiotic, let's give a different type. We need to get it the first time. So we do a catheterization. These infants actually do well. Give them a pacifier with a little sweeties, with a little sugar water on it. Mommy holds the hands, and I say, just talk to the infant. Have one nurse hold the legs. You get it in and out. It's uncomfortable, but it's done quickly. Most of all, the infant doesn't like to be held down. It's not the pain of the catheterization. And we know that specimen that we got will be accurate to which bacteria is causing that urinary tract infection. That is why we're going to catheterize. It's the best way. Now, infants don't need always to stick them antecubital to get blood like adults. You can do a CBC and a chem profile complete for 1.2 mLs of your of blood. That's hardly anything, right? But you need to know how to get it and to be safe with a child. Number one, you use a hospital approved heel warmer. Never take a washcloth and heat it up and put it on there because it could be too hot. And you will burn an infant's skin that easily. It's so sensitive. You also, when you're going to use that little heel stick lancet, make sure it's the one for infants and it's on the sides. If you put it in the back, that's where the calcaneus bone is, and it could hit the bone and cause osteomyelitis. So, for a trick, if you ever work with infants, you need blood. Number one, sit below the infant. Already have that heel warmed up. Hang that heel over the side of the bed or off the mother's lap. Very has all warmed up, and you're going to, alcohol it, get your little stick, and then slowly and easily, that leg is hanging down, you're going to see that blood pour right out. Boom, boom, boom. You don't have to squeeze it. You squeeze an infant's heel too much, it's going to bruise up and it's going to be painful. Intake output, what do you measure? This is always a question. You can intake anything that goes by mouth or IV. Many times we do flushes after giving medications. If a child is very small and is really concerned about fluid balance, we'll even measure that 1 or 2 mLs that we give before and after giving medications. And output, we do a little bit of everything. Sometimes you're going to see, and I've only once in my whole career I've done it, but I had a child who was profusely sweating and we wanted to know how much. We weighed a chuck and then we put that underneath the child and then we weighed it, making sure we didn't put any fluid on there. That would be an inaccurate output, but you can measure everything. And when you have a child that's in really precarious fluid balance, You want to know it really well. So giving medications to a child, putting them in your arm, leaning them back and giving them medications, many children don't want to take it. They don't like it. Mommy doesn't make them, and it's really a rough thing to do. Well, in this case, you can show them how to do it this way. Never squirt it to the back of the throat. They're just going to vomit. Put a little bit on the side, and hopefully they'll swallow. The other thing is teach the mother how to take a deep breath, and when they least expect it, medicine's in the mouth, you blow quick. And the child gets scared and gulps and takes the medicine. Now, years ago, before infection control, I used to blow in the mouth, when I knew I wasn't sick, right? But we don't do that anymore because of everything that's going on. So, family centered care, stress, hospital. We know separation anxiety, right? It's a big thing, the three stages of it. So, many children, are in and out, and it's, parents can rearrange and be there in the hospital. But what about that child who is with frequent hospitalizations? Parents have to work. That's just part of life. You got to make your finances. Also, other children at home need you to go to this function, that function. So many times these kids are left alone, and it's not because they don't want to be there. So remember separation anxiety if at all possible, and the parent can allow that parent to stay in the room. We know that cognitively impaired children need the parents the most. I've already said that earlier, okay? And we know males, 5 months to 6 years, need it even more than females. Apparently, females understand it more, according to research. Now we know regression happens. Part of, separation anxiety is, they regress. But just going into a hospital and seeing what's going on, these children are scared. They're stressed. What do? Finger goes back in the mouth, they start sucking, right? Some of the times where they're already potty trained, they may not, and they need to put a diaper on. Or all of a sudden, they're going to want to have a bottle where they've been in a cup forever and ever, right? So remember, there are children who are always independent, by themselves, and they get in a hospital, and now they need more care. Part of it is us as professionals knowing if we're on the next 3 days in a row, we should have the same kid, especially if we know the parents aren't there. We know children are scared. Part of it is all of the stuff we do. We're always touching them, always taking vital signs. Again, allow them to touch and play with this stuff. All right. The biggest stressor for any of the younger children, look, even here, preschoolers, infants know that they're gone. Toddlers for sure. That's the hardest, I think, of all of the areas. But preschooler, remember, separation from parents. School age children do a lot better if they keep their routine at home. So again, we can have parents stay there. Also, any of these age children is routine like at home. If they doing the same thing, and what does it mean? They get up around the same time, they have breakfast. If they can have the same types of breakfast, make sure that they get what they want. So it's the routine. When do they, take a nap? When do they bathe? All of these things, try to keep it on a schedule at home. It gives them comfort. They know what's coming next. So, parents in the room with the child, many parents want to partake and they want to do everything for the child. And you know something? Absolutely. But how do you do it safely? Well, number one, the first time, let's say this child's going to need dressing changes, for instance. I will do the dressing change. I am going to describe what I'm doing. I'm going to tell them why I'm doing, what am I looking for, etc., etc. The next time I'm going to say, Mom, would you like to do it? And I'm going to put gloves on with them too, right? I'm going to be there and watch them do it. And then I'm gonna, say, all right, you didn't do it like that, this and this. Maybe I might have to watch one more time, but after that, the parent's gonna go home and do this all the time. So I know that I have taught this child how to do it. And doesn't a child do better with the parent doing treatments than us? Absolutely. So making sure they're taught well. Now, chronic otitis media is an absolute chronic thing in kids. We think about all these upper respiratories, they're always with runny noses, right? Runny noses go to the back of the throat, goes up into the eustachian tubes, and now you have chronic otitis media. Our number one thing on these kids is this hurts. Have you ever had an ear infection? They hurt. Their tympanic membrane is bulging and it's a lot of pain. So make sure that number one, we give something for pain before even a doctor can even come look or even touch that ear. It's amazing to watch a kid coming in screaming and crying and holding their ear, a 3-year-old, give them a little bit of ibuprofen. 20 minutes later, their doctor comes in and the kid's running around the room. They feel better. They want to look in the ear, no problem. So it's a trick, but it's something we should do for all. Also, remember these children are going to be getting antibiotics. It's always staph. There's always staph in the upper airway. Make sure that they get all their antibiotics, okay? Make sure that they know that every dose must be given, or the antibiotic drops that go for externa in the ear. Everything needs to be given. Not when it's feeling better, stop. If it's 7 days, do 7 days. And then most of the time, physician will say, come and follow up with it. Bronchitis. So there's always questions between bronchitis and asthma. What's the difference, right? Well, they're both without fever, okay, usually. They're both non-productive, dry, hacking cough. But asthma is any time of the day, and asthma is expiratory wheezing. Okay? It's they get the air in, and the bronchus is so swollen, and the arterioles that are in there are so swollen, they can't get the air out. So you're going to hear that as the air comes back out of them. So bronchitis is also called tracheobronchitis. It is usually a virus, and it's that non-productive dry hacking cough that is worse at night, okay? And that worse at night will be bronchitis, okay? Now, croup. Croup is the oral airway, the laryngotracheal bronchitis. It is the larynx, the epiglottis gets a little swollen. And in this, it's inspiratory because it's the airway up top is swollen. So air can't get in. Down below, it's no problem pushing it back out. It's getting it in. And laryngotracheal bronchitis, or croup, has this very distinctive cough, and it sounds just like a seal. I mean, it is a loud barking cough. What they usually do with this is they'll just give a dose of a steroid, or they'll give you oral dose for 2 days, 3 days. I've seen one pill given, one shot given. It all depends on the doctor. But again, you're talking about croup, it's inspiratory stridor. When you don't treat croup, it can turn into that emergency, which is epiglottitis, okay? So croup must be treated or it can get even worse. Now, cystic fibrosis is a condition of too much mucus in the lungs, and it's in the small intestines. And it is inherited. Um, One of the things that if we didn't even know that there was a chance for cystic fibrosis, this would be an infant who wouldn't have a stool at birth. Usually, what do newborn infants do almost immediately after birth, even during birth? They're doing the meconium stool, right? You won't see it for 1 or 2 days, and one of the things they're gonna test them for is cystic fibrosis. As we go along in this program, there's a couple other one as we go, and we'll get into those. What test do? We do something called a sweat chloride test. If you were to lick a child, and I'm not telling you ever to lick a child with cystic fibrosis, but if you did, it would be very salty. They're losing salt like crazy out the pores, okay? So they literally measure how much salt is in the skin. So one, and all they do is they put probes and they measure it, and that's it. It's not like a blood test. They just look at the skin. Now, the other thing that happens, we've got the lungs full of mucus. We're going to be doing unbelievable good pulmonary care. We're doing those little vests that they have on, they're going brrrr, and they're vibrating, okay? And it's better than you with your hands pounding them and doing chest PT. And they need it morning and night minimum, sometimes even 3 times a day. And then they give aerosols that open up those lungs, right? Cause bronchodilation, and hopefully they're going to expel all of that extra mucus there. Now, the other thing that happens is their pancreas doesn't produce enough enzymes, and you do not have fat is not going to be used. It's going to be expelled in the stool. Therefore, you're going to have these large, bulky, the nastiest smelling stools that you've ever smelled. They are pretty bad, okay? Even for someone who's been around stools her whole life, these are bad ones, all right? Because they don't absorb fat, they don't absorb vitamins. So they're going to need some sort of replacements there. And just think about their diet. Fat is the highest caloric of fat, protein, and your carbohydrates, right? It's 9 calories per gram. This is something we have to replace with high protein, high caloric carbohydrate, and high calories diets. And we don't need to give extra fat because it's going to cause more foul smelling stools and abdominal distension, okay? So with these children, you're going to be careful. As I said, those lungs need taken care of. They always, it's like a petri dish, getting infection in there. So we're worried about nutrition and we're worried about their lungs. So it's stool things. So again, we need extra salt. Do not hold the salt on this child. Please give them a salt shaker. They need it, all right? And they need good protein, they need good carbohydrates, they need good calories, but they do not need any more fat. You do need to replace those vitamins, and again, really good pulmonary toileting on these children. Now, one of the things with cystic fibrosis is we can help the body a little bit. They don't have enough pancreas type of enzyme. We're going to give something called pancreatase. It's that little pill. There's little tablets in it, those little round balls, and there's also powder that they can take. Now, many children are not going to take those beads or whatever. We can sprinkle it on the food. And it's right when we're going to eat. If they're older, we want them those pills immediately before they eat. 30 minutes, even 15 minutes, like right before they're going to eat. And the body can digest their food and get some nutrition from what they're eating, which normally they wouldn't. Again, you never crush or chew any of these beads or enteric coated any medicine because that's why it's enteric coated to get through the stomach for what, the stomach uh, enzymes sometimes can make medication what they don't need. So never do that for any of them. If the capsule, you take it whole, and again, you can put it on the food. Now, if you use a powder, this is something like those respiratory medicines where you have to rinse your mouth when you're done. Same thing. You're gonna hurt the teeth, and mucosal gets all reddened. So make sure you rinse the mouth after they take the powder. And the one thing we tend to forget, believe it or not, is to increase the dosage as they get bigger. Children grow, and it's been a year since they've changed the dose of their pancreatase. And we're going to start to see weight loss and we're going to start to see other things because we don't have enough enzyme in there. So again, making sure these are important questions I just said. Now, women can get pregnant, okay? It is a high risk pregnancy, but a male does not produce sperm that has cystic fibrosis. I'm not completely sure the whole reason, but many men get in a relationship, get married, want to have children, and they can, 1 year after a double lung transplant, all of a sudden they can get sperm and they can produce a baby. So I don't know if there's a block in the duct, it's clogged, something, and then the cystic fibrosis, the lungs, they get that out. That's just enough to let the sperm through. I'm not totally sure, but this is an important concept. Men can only after a double lung transplant 1 year later. Now, many kids get tonsillectomies, adenoidectomies, and tubes all at once, many of them. But let's talk about post-tonsillectomy care. So usually it's an outpatient treatment. They go in, they get their tonsils out, and they get home. So you're going to be teaching if you're in the pediatric area. Avoid irritating or highly seasoned foods. Limit the activity. Think about it. They have cut these tonsils out and cauterize the area, and there's big scabs there. If they're up, moving, going crazy around, it's going to dislodge those scabs and they're going to bleed. I have seen a child 1 week post tonsillectomy come in to the triage room spitting up big blood clots. She had just gone for her 1 week checkup and she had somehow bust open one of the scabs and was bleeding. And I had to bring her into triage and resusc her with a whole liter of fluid. And this kid was little, so it was quite significant. So limit their activity, try to keep them calm. Cool liquids are great. Ice collars are good if they'll put them on. Younger kids like, no, I don't want that. Older kids will do anything. A younger kid, a popsicle, ice chips are great. Don't use red because you don't know if that's bleeding, right? And any bleeding should be reported to the doctor, especially sometimes you'll see this silent bleeding. You'll see your child just swallowing, and they're probably swallowing blood and they don't even know they're doing it. So frequent swallowing is bleeding, call the doctor. And older kids will have this pressure up into their ears and they can relieve it just like they're on an airplane, chew gum, right? Same concept. So just have them quieter, be careful with the foods you give them. And then we just need fluids. So asthma. Asthma is the expiratory wheezing, okay? It is a frequent cough. They get lost, short of breath, and you hear wheezing, but it's when it's not the inspiration, it's the expiration. Many times we teach them today to use those peak flow meters, and those peak flow meters, we can tell when it's going down and not enough air. And all we'll do is increase the amount of albuterol aerosols we give and try to prevent it. Chronic non-productive cough, expiratory wheezing. Usually, I have not seen a kid with asthma with a fever. It's usually just that cough and they just can't breathe. So rescue is the albuterol, Ventolin, Proventil, same thing, different names, okay? It should. What happens when you take the albuterol? It dilates the lungs inside and lets the air come out. So you should see less expiratory wheezing, okay? We do use a spacer, which is that bottom picture. It's a little mask. We put in that little meter dose inhaler on the end, push the dose, 1-2 dose. It goes in that little box and they breathe in and out, and then they're able to get their whole medicine, and it works great. Even young kids will hold it there for themselves. We do give corticosteroids in the case of, they're flaring to take care of it, but we also give them preventing those lungs from being hyperactive to whatever they're sensitive to. In children, we use something called Pulmicort. It's also called levoalbuterol, and it's morning and night. You could do the puffer, or they have the aerosols, depending. And again, it's preventative. And then they give what I call the Claritin for asthma, which is singular. It's an antihistamine specifically for the lungs, specifically for asthma. And then using that top picture, that is a peak flow meter. We can see, is the air they're breathing every day, is it going down? That means we got to do something. We need to increase that space in the air. We've already gone over croup. We've already looked at it. Treatment, as I said, depending on the severity. Well, they come in with a normal croup and barking. We'll just give that steroid. If a kid is really with that inspiratory stridor, a more severe part of it, they can give racemic epi in the aerosols. So epinephrine is a little tiny little amount. We put it in there and we put it on them, and that gets the epinephrine right to where it's swollen. And of course, the steroids. As I said, croup that's not treated properly will lead to epiglottitis. The epiglottis is that leaf-like structure that covers the larynx during your eating so that food don't go down into your lungs. Well, in croup, it starts to swell, but then you don't treat it and they're barking, more irritation. It swells more and it covers the whole larynx, and now they can't get air in. This is a respiratory emergency. You will see these children usually sitting forward, head bent to the side, trying to get that position like an old COPD patient, right? Trying to find a place where they can breathe. Maybe a little piece of air can get into here. They'll be drooling. This is a key, one of those signs and symptoms, drooling, tripod position, and their voice is muffled. They can barely talk, and you can see they can't breathe. With this child, be prepared. You could be doing either an emergency intubation, if you can get that endotracheal tube past that epiglottis into the larynx, or you might do a tracheostomy. So put both of those at the bedside for these children because they could be used. And we know airway is a very bad emergency when you can't breathe. Now, RSV is a common cold for you or me. For a young infant, all they need to do is suck, swallow, and breathe. And they're obligatory nose breathers. So you put mucus in their nose, they can't suck, swallow, and breathe. They can't eat. They can't breathe. All right. It's dangerous when you have a child that also was premature, has some lung issues, cardiac condition, any other thing that makes them more immunosuppressed. This can be an extremely deadly disease. So, and it is contagious. It's like an upper respiratory. It gets spread around really easy. Now, there is a treatment. It is called Synagis palvizumab, which is a biologic. It's once a month, usually from like November till like May. Now I live in Florida, so it's a little differently, but it's 6 to 8 months of the year. You'll not be tested on 6 or 8 months. It's just once a month they'll be given it, and it's those immunosuppressed children, and it does help prevent it. Another name we call it is bronchiolitis, all right? You're going to hear the names RSV or bronchiolitis. It's the same thing, different word. And I loved this picture because it really shows you adults, you don't feel good, but you can see infants, they're apneic, right? This is the complete difference in it. We suction the airway and see if they'll breathe. If they can't, they'll be admitted, they'll get IV, and we'll let them rest. Mononucleosis, kissing disease, no big deal. Epstein-Barr is a virus. Yes, it is a big deal. It is Symptoms of feeling like flu-like, sore throat, rash, fever, not feeling good at all. They go and they get treated, and it's not strep, it's not the flu, so they say, "Oh, it's just a viral pharyngitis," Tylenol, Motrin, fluid, rest. It's still not there. 4 or 5 days later, they give antibiotics. It does nothing. They go again now to urgent care, ER, and we say, "Okay, let's go ahead and let's draw some labs on this child." And they'll find that this is a mono spot test positive. This means they have mononucleosis. Well, as you look here, mono is a virus, Epstein-Barr virus. That's one that makes you feel tired virus. So that part goes into the symptoms here. What you need to teach these parents and this child is the spleen and liver could get swollen up like balloons. And these children should not be in any contact sports. They need to protect their abdomens. If you have other children at home that are roughhousing and rolling around on the floor, you need to protect this child's abdomen. I've told my class, I've seen a child come back a week later after those instructions. He was out on a tripod out in the middle of the Everglades, fell off, a four-wheeler, fell off and fell on his belly. His spleen exploded and he died by the time he came. So, Tylenol, Motrin, fluid, rest, protect the belly, no contact sports. Tetralogy of Fallot is all the right side of the heart. This is those blue spells. It's the pulmonic valve somehow closes and blood can't get up in there. We put these children in knee chest position, or older kids who are not fixed yet do what that little blonde boy does up there. They squat, and it just changes the position and pressures of their abdomen and their chest, and it pops it open and lets blood flow. There's acyanotic and cyanotic heart diseases, something that was gone over last week. One of the things I see common mistakes is not knowing when there is increased pulmonary blood flow. If you have a word that says stenosis or atresia, that means there is a narrowing or no blood flow. So that would never be an answer. Pulmonic stenosis, that is a narrowing, that's decreased flow. And like I tricuspid atresia, there's no blood going into the right ventricle, therefore nothing into the lungs, so that's decreased. It's when there's holes or spaces in between, and that is the atrial septal defect and ventricular septal defect, and that good old patent ductus arteriosus. Some children go home with congenital heart defects, and they come in later after they've tried going here, there, and everywhere, and they can't diagnose them. And finally, they say, "Well, maybe it's cardiac," and they were sent to where I used to work. And they look exactly what this says. They're a tachypnic, tachycardic, they're swollen, they're in congestive failure, they are not saturating the way they should, so they're bluish. You hear murmurs, and many times you're going to see those decreased pulses in the lower extremity and okay in the upper extremities. I've seen coarctations go home 3 months later, come in that they need treatment. A patent ductus arteriosus is fetal circulation. It is a connection between the aorta and the pulmonary artery, and this is there to put oxygen from the lungs to the body when the heart is congenitally in a way where it can't. And we need to sometimes evaluate that ductus and see if it's open or not. Well, you're going to hear a machine-like murmur. And those blood pressures are going to be, the diastolic is going to be really low. Normal blood pressure on a newborn, 60/40. You might see 60/18. And that's telling you that it's still open. Now, the Transposition of the great artery is when the aorta and the pulmonic system are switched completely. So you're not getting any oxygen to the body. So this is one that we need the prostaglandins to stay open. Now, when you're pregnant, moms produce a hormone called prostaglandins. When mom delivers, mommy's not there no more. If we need to have it open, like in transposition of the great arteries, we have a synthetic prostaglandins that is a continuous, slow IV infusion. And it puts the prostaglandins there and it keeps it open. And what does prostaglandins do? Very important. It there for oxygen saturation and it helps the heart to pump effectively. And because now we're getting oxygen everywhere, it prevents central nervous system involvement because now we're getting oxygen to the brain where it needs to go. As I said, atresia and stenosis, know what those words mean. You're going to see those words. A is without, there's no opening. Usually that is between the right atrium and the right ventricle, okay? Tricuspid atresia. Nothing is going to the lungs. And then stenosis is just, it's narrowed. You'll see that on the pulmonic valve and the aorta. There's still blood going, but it's decreased. Now, post-op, children will be getting chest tubes. Is to keep the lungs inflated and get rid of extra fluid, whatever, to get extra blood out. Now, children are afraid of hurting, and it does hurt. It burns. It's one of these things that burns, and adults have told me it's intense burning. Make sure, number one, you medicate for pain, right? To do that safely, you take vital signs. Then you're going to take and give pain medicines. You're going to explain to the children, tell them what's going to go on, having them sit up a little bit in the bed and tell them that it's going to hurt a little bit, but I'm going to give you medicine. It's going to help a lot, and I'll hold your hand. And sometimes that's all they want, all right? And then after it's out, we just don't put lotion and powder on it. Sometimes a little Band-Aid, little steri strip. That's about it that goes over it. Remember, transplants, the biggest thing is rejection. Rejection is the biggest. It's not infection, it's rejection about post-transplants. And they're going to have to take immunosuppressants their whole life. Rheumatic fever is caused by a strep throat. And there's a lot of really serious things: fever, joint pain, rash, the nodules. The one thing we're concerned about if it's gone on too long is the heart valve damage. And it's the mitral valve. So kid comes in complaining of a sore throat, fever, it continues. Now all of a sudden they've got this. Many times the parent is like, doesn't go in yet because, we know what's happened here. It's when they get chorea, those really weird movements. Even that can be turned around, and it is a long term of antibiotics. Hopefully, the heart doesn't have damage yet, because once it happens, you cannot turn it around. Digoxin in children. We do it just like adults. We look at the apical pulse, we listen for a minute, we check potassium, we check drug levels, we check their heart rate. And sometimes in infants, the only thing you might see is vomiting. You may not see anything else. So be aware. With digoxin, it is safe. I mean, I've been giving digoxin to infants for 30, 40 years already. So, I mean, it's very safe. But remember to do your due diligence and to check these things on these children, because you may only see vomiting. Better to hold it, get a digoxin level, make sure it's safe before you give it. Post-catheterization, once we do an EKG and an echo, we find out there's a possibility of congenital problems, we will be doing cardiac catheterization. They thread the femoral artery and the femoral vein, and they go into the heart and they look. Once they come out of the catheterization, somebody is going to be holding that area of the femoral artery and femoral vein until it stops. And then they'll put a pressure dressing. Older kids will get a sandbag put on top of it. Number one thing you need to worry about is bleeding, because you're not going to get somebody. An infant can bleed his whole blood out by the time you get somebody. Put two fingers right above, the leg is down here, the heart's up top, right above, so you can look at those sites and put pressure on it so that you make sure it's not bleeding. And then you can have somebody call for help at that point, because the treatment is to make sure that you put pressure. These children are on bed rest for 24 hours, keeping that leg straight. You're going to make sure they're hydrated, whether through IV or orally, and then we'll be checking glucose. Sometimes they don't get glucose in the procedure, and sometimes their glucose levels are low or even high when they come back. ITP, this week's lecture. ITP, P platelets, low platelets, thrombocytopenia. It has to do with bleeding. So these children are going to have unexplained nosebleeds, unexplained little petechiae, bruising, and they don't know where it all came from. Usually, this is from an upper respiratory infection, and you will see platelets 20,000 or lower. How do we treat it? Well, IVIG. Well, number one, we take a CBC and we find the platelets low. That's the first thing. Then we're going to be giving them IVIG, support their immune system, and then anti-D. It's also given. Now, as nurses, let's say this child's admitted initially to be watched and for initial treatment, we need to know that we're not going to give any needle sticks, venipunctures that are unnecessary to this child. We're going to be looking at their gums, nose, urine, stool for bleeding, and we're going to be watching those CBCs. And then maybe, sometimes, we'll give corticosteroids. HIV, the one thing about HIV, it's when we talk about it, a lot of times it's because HIV with a pregnant mother. And what we want to do is make sure that we boost that infant's immune system so that we can prevent them from getting the disease. Now, some of the things that can happen, this opportunistic, in the lungs, it's PCP pneumonia, pneumocystic pneumonia. GI, it could be that candida. And then, of course, the integumentary too is candidas. And those are the things that you see with it. With candidas, we give that nystatin, put it in the mouth, can help with it, and these children, our goal, as I said, is infants to support their immune system, giving those antiretroviral drugs, especially for the first year. Always with anything, nutrition, and then if we see any symptoms, to treat them as they go, because you're expected to see something. Anemias, we have iron deficient, megaplastic, hemolytic. Iron deficient, most common. All it is not enough iron, and it's usually all dietary. So it's either change the diet or let's add a drug. It could be orally, or we can give injections of iron dextran. It's Z-Track. It's a deep IM. Okay. These kids, when their H and H's are low, they don't have oxygen. They don't have iron. They're going to be tired. So remember that as we're treating them. Megaplastic is B12. So make sure that we give either the folic acid or the B12 to them. Again, it's the replacement, making sure they have it. And hemolytic is sometimes with some medications, whatnot, infections, the cells explode. You don't see that as much. Sickle cell is that S shape, in that C shape, sickle shaped cell that gets clogged. Cooley's anemia and sickle cell is the African American. Cooley's is Mediterranean inherited. And this has to do with, I call them the rectangular shaped cells that burst. And when it bursts, it throws out iron. And of course, you lose your oxygen and you can become toxic with iron on this one. So you have to do therapy to get rid of the iron. And then aplastic has to do with white blood cells, red blood cells, platelets, and they're not producing it. When we're giving blood, remember any signs and symptoms, first thing you're going to do is turn it off. We always follow procedures. And one of the things that can happen is circulatory overload. You gave too much too quick. And these are the symptoms you see: shortness of breath, those veins in the neck come up, and a dry cough. And again, this is something you'd call the doctor for. So a little more about sickle cell. We know it's the clogging of the cells in the bodies where it bifurcates, can't get through. So usually it's due to dehydration. We need to dilate and put some heat to vasodilate the area to try to get the blood going through because it's backing up, swelling, and it's full of pain. So priority is IV fluid bolus. Okay. In the other hand is my pain medicine, but priority is going to be a bolus of fluid. One of the things about cancer is we are literally taking and destroying even a lot of good things in there, right? We know that we're looking at the white blood cells because that is leukemia. We're getting rid of it. But there's something that happens where we look at neutrophils. Now, usually questions when they're talking neutrophil on your NCLEX, HESI, has to do with neutrophil counts, and they're setting you up with types of clients. Which one would you see first? Well, you have any child, I don't care what they're in there for. If you see a neutrophil count below 500 and they have a fever, this is your priority patient because they have absolutely nothing to fight infection. They can go into septic shock very quickly. Okay. So neutrophil count should be somewhere about 1200 minimum, but usually over 2000. Okay. Leukemia is all your white blood cells. They're being produced, but they're immature and they're just not working. So remember, with leukemia, we're going to start chemotherapy. Our goal is to start that initial part called induction, and that goal is to achieve remission. Yes, we're going to give more chemo to follow, but we blast these children with really strong chemotherapeutic agents to get rid of the cancer there. Okay. But there's always some hiding, as I call it. So that goes on longer. But induction is to achieve your remission. And always make sure that we're giving antiemetics and doing things to make this as comfortable as we can. Osteosarcoma, cancer of the bones. Many times it's the femur. That's why you have pictures of legs here. You have to take out the whole femur bone. Our goal, if we can, is to salvage the bottom part of the leg. And they take it, turn it around, and they try to put it back up into the hip joint. And the reason is to have somewhere to be able to put a prosthesis so that they are more mobile. This is adolescent stage, body image. They want to be able to walk around easier, right? So they sometimes got to do amputation, but our goal is to salvage. With leukemia, we know it's the white blood cells and we're giving chemo, and sometimes it just doesn't work. And sometimes we have to do bone marrow transplants to help. Well, I do two things to tell you how to remember these words. Autologous is automatically mine. I want that one. Automatic, that's good stuff. Automatic, no question about it. Don't got to think about it. If I have, let's say, some of my cord blood saved on my infant, that's my number one choice. Now, allogenic is all, everybody else, all others. You do not have to have the same blood type. We know that a sibling is the best, but it doesn't have to be. So auto is me, allogenic is all the others. Brain tumors, taking up space in the brain. What symptoms do you see? Well, these children are going to get a headache. They're going to be vomiting, and the vomiting has nothing to do with eating, and the headaches, they can wake them up at night. And that is part of the symptoms of it. With brain tumors, usually it's radiation, and then they'll do surgery to get it out. Again, we never remove those marks. And then Hodgkin's and non-Hodgkin's lymphoma. There are lymph glands in the body. So Hodgkin's is enlarged, firm, non-tender nodes, lymph nodes. You might see the neck with its big things sticking out, but if you touch it and wiggle it, it doesn't hurt them. Hodgkin's is from the shoulders up, big things you can see. All right. They'll treat it with radiation and try to get rid of it and chemo. Non-Hodgkin's is what we call diffuse. They're really tiny and they're everywhere else. You don't see them. They're diffuse. That means they are in the armpits and the groin, everywhere. So they're hard actually even to see. Hodgkin's, big ones you see, they're from the shoulders up. Non-Hodgkin's, diffuse and everywhere. And here is, what we say about it. Again, they're both treated almost the same way, but those are the differences. CPR for a kid under 8 years old, remember, we always yell for help. If we know that they are not with a pulse, we're going to start doing care and then call for help. I mean, in the hospitals, we're pushing the code blue button on the bed as we're starting anything. But this is just to reiterate it. We've also put in the list of what to do for medical personnel. We know that, lay people out on the street do things different. We just start CPR now. But in the hospital, we still do give breaths, etc. So 5-dosage calc. Remember, there is an insulin and heparin question. So remember, they are DHQ questions. You have a dose, they send something, and it's in the quantity of a bag of how much mLs. These are all your cahoots. If you haven't gotten them, you should have been sent by your professors. If not, you can always send me a message. I'll send them to you. I wish you good luck. I did go over a little bit today. I apologize, but I got everything in that you do need. Any questions?
Professor, I just wanted to make sure that for